Welcome to the audio digest of the American Journal of Psychiatry. This is Michael Roy with highlights for the month of February 2009. This month we'll begin with two articles on bipolar disorder. The first identifies factors related to the emergence of mania during antidepressant treatment for bipolar depression. The other reports on manic symptoms observed during bipolar depression among participants in the Systematic Treatment Enhancement Program for Bipolar Disorder, or STEP-BD, a large 22-site study sponsored by the National Institute of Mental Health to examine clinical phenomenology, longitudinal course, and treatment effectiveness. We'll next examine the attitude of older adults toward enrollment of non-competent subjects in Alzheimer's disease research. We'll also highlight 3 studies on brain dysfunction in schizophrenia. One that looks at the association between cerebral deficits and clinical symptoms in antipsychotic-naive first-episode patients. Another that examines whether altered amygdala activity is related to clinical state or to genetic risk. And a third that focuses on brain structure in patients with relatively intact cognitive functioning. We'll conclude with a report on a deficit in odor detection sensitivity in patients with schizophrenia and its implications for cyclic AMP signaling. But we start with bipolar disorder. In the STEP-BD study, more than 40% of the patients reported a switch to mania or hypomania that was associated with taking antidepressants. Because identifying risk factors for this outcome could be clinically valuable, Mark Fry and colleagues investigated correlates of treatment-emergent mania associated with antidepressant treatment in bipolar depression. This analysis included 176 patients who had confirmed bipolar disorder and were depressed. They were followed prospectively in a 10-week antidepressant trial and were monitored with standard mood ratings. They were also being treated with a mood stabilizer or antipsychotic. The participants were classified into 3 groups according to their scores on a version of the Clinical Global Impression Scale modified for bipolar disorder. The 3 groups were patients who responded to antidepressant treatment, those who did not respond, and those with treatment-emergent mania or hypomania. The group with treatment-emergent mania had higher scores on 3 items of the Young Mania Rating Scale: speech, thought content, and increased motor activity or energy. To further explore the relationships between scale items and treatment-emergent mania, the authors conducted a factor analysis to identify clusters of items from the mania scale that varied together. An analysis of variance based on the factor scores then determined whether these features were also related to development of mania. 4 factors were identified, but only one was related to treatment-emergent mania. This was a composite of motor and verbal activation. Thus, in 2 different analyses, increased motor activity and speech were significant predictors. Unlike other studies, this one did not show a link to any past clinical variable. Dr. Fry and colleagues suggest that the combination of activation, pressured speech, and language or thought disorder may be a surrogate marker for a depressive mixed state. There's increasing recognition of the presentation and clinical characteristics of a depressive mixed state, although it's not operationalized in DSM-4 or ICD-10. Several definitions have been proposed, but in general, a depressive mixed state is considered a syndromal episode of major depression plus several symptoms of mania or hypomania. It's distinct from the traditional mixed episode, which is major depression plus 4 manic or mixed symptoms. Currently, a full mixed episode is classified as a manic episode subtype. The findings of Dr. Fry and colleagues suggest that patients with bipolar depression should be examined for motor activation, pressured speech, and racing thoughts before antidepressant treatment is begun. The risk of treatment-emergent mania or hypomania should be carefully weighed against the potential benefit of the antidepressant. In a related article, Joseph Goldberg and colleagues report manic symptoms during depressive episodes in 1,380 patients with bipolar disorder who are participating in the STEP-BD study. These individuals had either type 1 or 2 bipolar disorder and met the criteria for a major depressive episode when they entered the study. The authors hypothesized that concomitant manic symptoms would be more common than rare, and that these mixed presentations would be related to rapid cycling, greater severity, psychosis, comorbid substance abuse, and poorer psychosocial functioning. Manic symptoms were determined with the affective disorders evaluation. Scores of 1 or higher indicated symptoms with at least moderate severity. The patients were divided into 3 groups on the basis of their total number of symptoms. One group had no manic symptoms. Another had 1 to 3 symptoms, which was considered subsyndromal mania. The third group had 4 or more symptoms, which was considered a full mixed episode. Of these depressed bipolar patients, fewer than 1/3 had no manic symptoms, 54% had subsyndromal manic symptoms, and 15% had full mixed episodes. Compared to the patients with no manic features, those with subthreshold or fully mixed mania were significantly more likely to be male, to have bipolar II disorder, to have had rapid cycling in the past year, and to have attempted suicide. They also had an earlier onset of illness. Those with full mixed episodes were significantly more likely to have a history of substance abuse or dependence, as compared to those without manic symptoms. The three groups did not differ in the mean number of days with depression in the past year, but those with any manic features had more days with an irritable mood or abnormal mood elevation. The most common manic symptom was distractibility, which was present in more than 50% of the patients. Flight of ideas, or racing thoughts, was found in about 30%. Lithium use at the beginning of the study was significantly less common among the subjects with full mixed episodes or subsyndromal mania compared to those with no manic symptoms. However, antidepressant use was not higher among the subjects with mixed features. The mean total number of manic symptoms was actually lower among subjects taking antidepressants than among those not taking them. This suggests that the presence of manic symptoms was not merely an artifact of antidepressant use. Next, we'll highlight the study by Jason Karlawish and colleagues on the attitude of older adults toward enrollment of non-competent subjects in Alzheimer's disease research. Research on Alzheimer's disease that doesn't offer any possible benefit to non-competent patients is controversial. To examine the views of potential subjects, the authors questioned healthy older adults about their willingness to participate in future research if they developed Alzheimer's disease. The opinions were based on two hypothetical studies on possible diagnostic tests for Alzheimer's disease biomarkers. One study was meant to represent minimal risk to the participant and included a blood draw. The other was used to represent greater than minimal risk. It involved a blood draw plus lumbar puncture. Nearly 600 people were interviewed. They were 65 or older and were recruited from several medical clinics and one senior center. The first part of the interview tested the respondents' understanding of basic research concepts. If this was adequate, the interview proceeded to a survey of views about research involving people with Alzheimer's disease. The person was also asked whether he or she would be willing to have a proxy for decisions regarding participation in research. Next, the two hypothetical studies were presented, in random order. For each study, the interviewer asked whether the respondent would be willing to provide advance consent for the study if he or she developed Alzheimer's disease. Participants who had indicated a willingness to have a proxy handle decisions were asked whether they would grant leeway to their proxy to override their advance consent. Part 3 collected demographic information and rated the subject's altruism, trust in the healthcare system, attitudes toward research, and perception of Alzheimer's disease. Respondents were classified as either willing or not willing to participate in the proposed studies. Persons were considered not willing if they indicated that they wouldn't want to have a proxy for decision-making regarding participation, and they would not grant advance consent. Persons were also considered not willing if they would allow a proxy, but would not grant advance consent and would not grant their proxy leeway over that advance directive. All other persons were defined as willing to participate. For the study involving just a blood draw, 83% of the participants said they were willing to grant advance consent, compared with 48% for the lumbar puncture study. When these preferences about advance consent were combined with leeway granted to the proxy, more than 92% had preferences that would allow the blood draw study, and 3/4 would allow the lumbar puncture. For both studies, willingness to be enrolled was linked to higher scores for social responsibility, trust in the healthcare system, and favorable attitudes about research. Willingness to participate in either study was not related to the perceived threat of Alzheimer's disease, being close to someone with the disease, or a history of working in the medical or scientific field. Willingness to be enrolled in the blood draw study was more common among persons with more education, those who reported less financial burden, and those who chose a spouse or partner as their proxy. But these associations were not seen with the higher-risk lumbar puncture study. Persons who reported being in a racial minority group were less willing to be enrolled in the lumbar puncture study, but this effect disappeared when attitude toward research and minority status were analyzed together. Now, we'll turn to brain structure and functioning in schizophrenia. We'll begin with an article that looked, via optimized voxel-based morphometry and resting state functional connectivity, at the association of cerebral deficits with clinical symptoms in antipsychotic-naive first-episode schizophrenia. A group from West China Hospital in Sichuan, China, examined regional brain volumes in 68 first-episode patients with schizophrenia who had not yet received antipsychotic medication. The estimates were compared with those for healthy subjects. The brain volumes were determined by using magnetic resonance imaging and voxel-based morphometry. Compared to the healthy subjects, the patients had lower gray matter volumes in the right superior temporal gyrus, middle temporal gyrus, and anterior cingulate gyrus. Each of these deficits was correlated with lower scores on the Global Assessment of Functioning scale and worse scores for positive symptoms, thought disturbance, and paranoia from the positive and negative syndrome scale. The lower volumes in the right middle temporal gyrus and anterior cingulate gyrus were also correlated with more severe activation and impulsive aggression. The functional connectivity between each of the three regions and the rest of the brain was analyzed on a voxel-wise basis. There were no significant differences between the patients and the comparison subjects. However, among the patients, the functional connectivity of the right middle temporal gyrus to the putamen and to the precuneus was positively correlated with the score for thought disturbance. Also, connectivity of the right superior temporal gyrus to the cingulate gyrus was negatively correlated with the total PAN score. Connectivity of the right superior temporal gyrus to the precuneus was negatively correlated with scores for negative symptoms and anergia. In an editorial that examines this study as part of a larger discussion on connecting brain structure and function in schizophrenia, Jason Tergelis states that it's important to note that the causal relationship between gray matter volume and functional connectivity is unknown, and that there was no overall difference in functional connectivity between the patients and comparison subjects. He does indicate, however, that the study applied a very conservative correction for multiple comparisons, which might have limited sensitivity to group differences. Next, we report evidence that altered amygdala activity in schizophrenia is related to clinical state and not genetic risk. Activity in the amygdala was induced by presenting images of faces, because face processing depends on the functioning of the amygdala. To determine whether amygdala dysfunction in schizophrenia is caused by the disease or is genetically determined, Roberto Rossetti and colleagues compared 34 patients with schizophrenia, 29 unaffected siblings, and 20 healthy comparison subjects. Brain activity was measured by functional MRI, as the participants matched facial images with the same expression, either angry or afraid. Reactivity of the amygdala was lower in the patients than in their unaffected siblings or the comparison subjects, and the siblings did not differ significantly from the comparison subjects. Thus, the patient's dysfunction in the amygdala appears to be related to disease state and not to their genetic vulnerability. Also, the patients had less functional coupling between the amygdala and the subgenual cingulate compared to the other two groups, and this coupling was negatively correlated with antipsychotic dose. As Dr. Tergelis points out in his editorial, the suggestion that some cortical functions are related to genetic risk for schizophrenia, whereas cortical responses related to amygdala function are not, adds important insight about possible disease mechanisms. However, as before, the exact nature of amygdala response and connectivity dysfunction in schizophrenia remains unknown. While the study found decreased amygdala responses to emotional faces, other studies have found the opposite. These disparate findings may reflect the different procedures for eliciting responses. Since cognitive deficits are a central and prominent aspect of schizophrenia, it's noteworthy that some patients have scores on cognitive tests that are normal or nearly normal. The pathophysiological significance isn't clear. These patients could differ in the severity of a single disease process, or their illness may differ fundamentally in its underlying pathogenesis. Thus, another study in this issue focuses on neuropsychological near normality and brain structure abnormality in schizophrenia. To test each of these possibilities, Bruce Wexler and colleagues compared MRI images of 21 of these patients with images for patients who did have neuropsychological impairment. If those with nearly normal cognition had morphological abnormalities that were qualitatively similar to those in the impaired group, but were quantitatively more limited, that would suggest a milder form of the illness. If they had qualitatively distinct patterns of volumetric abnormalities, that would distinguish them from the impaired group. Neuropsychological status was based on the patient's performance on 4 tests of attention and verbal and nonverbal working memory. Those whose overall scores were more than 1 standard deviation below the mean for a group of healthy subjects were considered to have neuropsychological impairment. The near-normal group scored within half a standard deviation of the healthy subjects. Both groups of patients with schizophrenia had markedly lower gray matter volume throughout the cerebrum and markedly larger third ventricles compared to the healthy comparison subjects. In several regions, gray matter volumes were actually smaller in the patients whose neuropsychological functioning was near normal than in the impaired patients. The magnitude of the gray matter differences was striking, given the absent or modest cognitive deficits. The measurements of white matter presented a different perspective. The patients with neuropsychological impairment had markedly smaller white matter volumes and larger volumes of the lateral ventricles than the healthy subjects. This difference wasn't seen in the patients without cognitive impairment. In other words, the differences in structural abnormalities between the two schizophrenia groups appear to be qualitative and not simply quantitative. The relatively normal white matter volumes in the near-normal patients and the marked abnormality in the impaired group suggest that white matter pathology may play a primary role in the cognitive deficits observed in most patients with schizophrenia. Returning to the editorial discussing the connection of brain structure and function in schizophrenia, Dr. Tergelis points to a growing body of literature that suggests that schizophrenia is caused not by local lesion-like brain pathology, but by dysfunction of functionally and anatomically connected networks of brain regions. White matter forms the physical connections of these functional networks, and evidence suggests that it's compromised in schizophrenia. Structural evidence comes from postmortem studies showing reductions in oligodendroglial cells and ultrastructural abnormalities in myelin, and from in vivo diffusion tensor imaging studies that suggest alterations in white matter tracks. Genetic studies have implicated genes involved in oligodendrocyte and myelin-related processes. Functional connectivity studies of schizophrenia have also been considered recently with increasing interest. The finding of altered default mode connectivity has been widely replicated. It's consistent with numerous reports of reduced synchronized activity between brain regions in the default network and other areas. For example, an elegant study by Judith Ford and colleagues demonstrated that a deficit in neuronal synchrony is directly related to auditory hallucinations. We'll conclude with Bruce Turetsky and Paul Moberg's finding that an odor-specific threshold deficit implicates abnormal intracellular cyclic AMP signaling in schizophrenia. Olfactory deficits are common in schizophrenia, but their underlying pathophysiology isn't known. Recent evidence has suggested that brain signaling mediated by cyclic adenosine monophosphate, or cyclic AMP, may be disrupted in schizophrenia. Since cyclic AMP mediates signal transduction in olfactory receptor neurons, this could contribute to the etiology of the olfactory deficits. The authors tested this hypothesis by determining detection threshold sensitivities to two odorants that differ in their activation of this intracellular cyclic AMP signaling cascade. The two odorants were citral and lyrol, both of which have fruity or floral scents. However, citral strongly activates adenyl cyclase, thereby increasing cyclic AMP levels. Lyrol elicits only a weak response. For each subject, the authors estimated the threshold for detection of each odor by determining the concentration the person could reliably identify as stronger than mineral oil. Smoking status was included in the analyses as a moderating factor, but was not significantly related to odor acuity. 3 groups of subjects were compared: 30 patients with schizophrenia, 19 unaffected first-degree relatives, and a healthy comparison group. Both the patients and their relatives were significantly less able to detect lyrol than citral, the odor that evokes a stronger cyclic AMP response. The comparison subjects showed no difference in sensitivity to the two odors. The authors also tested the associations of the olfactory measures to symptom ratings, medication dose, age at onset, and duration of illness. None of the relationships was statistically significant. The odor-specific hyposmia may indicate a genetically regulated disruption of cyclic AMP-mediated signal transduction. This finding is consistent with growing evidence that cyclic AMP is dysregulated in schizophrenia. However, this hypothesis is not inconsistent with other models of schizophrenia pathophysiology. Altered cyclic AMP levels can be secondary to either glutamatergic or dopaminergic dysregulation. Olfactory deficits in schizophrenia are examined by Akira Sawa and Nicola Casella in their editorial on the peripheral olfactory system for clinical and basic psychiatry, which they describe as a promising entry point to the mystery of brain mechanism and biomarker identification in schizophrenia. In the rest of medicine, patient tissues that express biological mechanisms of disease have been invaluable. In psychiatry, autopsied brains may provide us with cellular and molecular changes at the end stage of the disorder. However, conclusions can be limited by many confounding factors, including long-term exposure to medications, substance abuse, and smoking. A biological system that can overcome this limitation would be welcome. Olfactory deficits have been studied extensively in schizophrenia. They're found in fewer than 15% of the general population, but are observed in the majority of patients with schizophrenia. Impairment of olfactory identification has been proposed as a premorbid marker of transition to the onset of schizophrenia. First-degree relatives are intermediate between patients and normal comparison subjects in their ability to identify odors. This suggests that abnormalities in odor identification are related to a genetic predisposition to schizophrenia. The report by Turetsky and Moberg raises the possibility that the olfactory system will provide the tissue source needed to better understand the molecular cell biology of schizophrenia. This work has several significant strengths. First, instead of measuring olfactory identification, it estimated olfactory detection threshold sensitivity, the ability to detect a weak odor concentration. In this way, it may have succeeded in depicting specific abnormalities associated with the peripheral components of the olfactory system, such as olfactory epithelium and olfactory bulb. A question that usually arises about olfactory deficits is the level of the olfactory system that's responsible. Dysfunction of peripheral components may reflect deficits in specific cellular mechanisms, whereas odor identification is more complex and may involve the more inaccessible central brain areas involved in other cognitive deficits in schizophrenia. The second noteworthy aspect of the findings is that they're specific to an odor that can activate a key intracellular signaling system involving cyclic AMP. This indicates a particular susceptibility in schizophrenia. Since a parallel deficit was observed in the patient's relatives, the deficit may be genetically mediated. The present work also raises the possibility that a simple clinical examination may uncover a deficit of intracellular signaling related to the etiology of schizophrenia. Further study of olfactory epithelium by means of nasal biopsy may be an important step. Olfactory epithelium is a unique tissue where neurons of the central nervous system exist and undergo regeneration and differentiation. These are key features of neurodevelopment throughout life. Thus, olfactory epithelium and its synaptic targets in the olfactory bulb may provide a snapshot of morphologic and molecular neurodevelopmental processes even in adults. Susceptibility of a specific signaling cascade associated with a key disease mechanism has been previously reported in other brain disorders. Huntington's disease is caused by an expansion of glutamine repeat in the causal genetic factor huntingtin, and mitochondrial abnormalities are reported in brains from patients with the disease. Increased susceptibility to mitochondrial toxin in the lymphoblasts from patients with Huntington's disease is associated with a genetic mutation. By analogy, olfactory neuronal cultures from patients with deficits in detection threshold sensitivity to Lyrol, but not Citralva, may display an abnormal cyclic AMP response to Lyrol. It may be possible to explore a potential link of these phenotypes to genetic schizophrenia susceptibility factors associated with cyclic AMP signaling. This concludes the audio highlights of the February issue of the American Journal of Psychiatry. Please note that the full text of these and other articles may be viewed online at our website, ajp.psychiatryonline.org, including all author affiliations and disclosures. We also welcome comments regarding this audio program. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Thank you.